Hello, everyone, and welcome to NCSL's webinar on COVID-19, Leveraging Medicaid for Coverage Testing and Treatment. My name is Emily Blanford, and I will be moderating today's webinar. I am a program principal with NCSL, and I focus on Medicaid policy. Today's webinar is a platform for information exchange and engagement. Over the next 60 minutes, we encourage participation through our chat box, so feel free at any time to type your questions in the chat box, which is in the lower left-hand corner of your screen. To begin building some comfort with the chat function and also to learn who is on the line today, I invite you to type in the state from which you're joining us now if you'd like. I also want to briefly mention the Resources tab on the webinar platform. Above the presentation, you will see a couple tabs with one of them labeled Resources. Here you can find and download a PDF version of today's PowerPoint presentation. Another tab is labeled Speaker, where you can find the bio of today's speakers. You can also access these tabs at any time during the presentation. Today's webinar is also being recorded and will be available on NCSL's website within the week. So for those of you not familiar with our organization, the National Conference of State Legislatures, NCSL, is the bipartisan membership organization that serves the state legislators and legislative staff of the states, commonwealths, and territories. NCSL provides research, technical assistance, and opportunities for policymakers to exchange ideas on the most pressing state issues, and is an effective and respected advocate for the interests of states in the American federal system. Now, before we jump into today's program, just wanted to briefly highlight a few of the COVID-19 resources available to you all from NCSL. NCSL developed a web page to house our comprehensive resources on the state and federal response to COVID-19. To view this information, go to NCSL's website at ncsl.org. You'll see a banner at the top. Click it, and it will take you to the NCSL Coronavirus Resources for States. Here you can find information on state policies and responses in areas such as continuity of government, education, fiscal issues, elections, criminal justice, and more. Additionally, today's webinar is the first in a four-part series on COVID-19 and the U.S. healthcare system. In this series, we'll explore how various aspects of the U.S. healthcare system, including Medicaid, private health insurance, health workforce, and healthcare facilities, are impacted by and responding to the COVID-19 pandemic. We'd like to thank the Commonwealth Fund for their support of this webinar series, and I encourage you all to save the date for these upcoming webinars. For today, we will be discussing how state Medicaid programs are responding to the COVID-19 pandemic. Covering nearly 1 in 5 individuals in this country, Medicaid programs are in a unique position to provide resources in response to COVID-19. Our first speaker, Haley Nicholson, Senior Policy Director with NCSL, will provide an overview of federal actions impacting Medicaid programs, including recent legislation and federal guidance. Then we'll hear from Jack Rollins, Senior Policy Specialist with the National Association of Medicaid Directors, NAMD. Jack will discuss trends in Medicaid COVID authorities, or in other words, trends regarding how states are using new federal flexibilities in light of the pandemic. Lastly, we wanted to share an example of what's happening on the ground in states. So we will be hearing from Josh Bloch, Budget Director with Colorado Medicaid, who will share specific actions Colorado has taken in response to COVID-19, including policy options as well as fiscal considerations. So with that, I will turn it over to Haley Nicholson to share federal Medicaid actions.
Great. Thank you, Emily, and good afternoon, everyone. So these are a few of the topics I'm going to go over today in regards to federal action. So let's get started with congressional legislation. On March 18th, the President signed, Families First Coronavirus Response Act. This is the second piece of COVID-19 relief legislation that was passed, and it addressed access to COVID-19 care for state Medicaid programs in a couple of different ways. One of the biggest ways that's been discussed since the bill passed and is signed into law, it gave states the ability to be eligible for a 6.2 increase in their federal medical assistance percentages, also referred to as FMAP. And this is important to note, applies to regular FMAP and is not for administrative expenses or the Medicaid expansion population that was authorized under the Affordable Care Act. Also for states that take the increase to qualify, They need to provide COVID-19 testing and treatment with no cost sharing requirements, so copays, deductibles, etc. And states cannot make changes to Medicaid eligibility that are more restrictive than the requirements that were in place when the state of emergency was declared, nor can premiums be increased. And so a few other pieces of this bill that included some Medicaid provisions. It provided states with an option to cover COVID-19 testing and test-related visits for uninsured individuals. And so this means the federal government will provide 100% FMAP for this option, so covering the testing costs should the states decide to choose that option. It also included no cost sharing for Medicaid and Children's Health Insurance Plan, also referred to as CHIP enrollees, and 100% FMAP to cover the costs, and increased Medicaid funding to U.S. territories for all medical services for the next 2 fiscal years. The second piece of legislation I want to discuss is the most recently passed COVID-19 response bill, the CARES Act. There were a few Medicaid provisions within that bill. 2 included the extension of a few Medicaid programs, one including Money Follows the Person demonstration program will now have funding until November 30th, 2020, and continued protection against spousal impoverishment. A quick reminder, Money Follows the Person is a demonstration program that supports states in their efforts for rebalancing long-term services and support systems so an individual can choose where they live and receive services. Spousal impoverishment is a program that originally had provisions going back that were passed in Congress in the late 80s, and is helping ensure for a spouse who is still living at home while their partner is receiving services that they will not rapidly deplete their savings. The bill also included an updated from the previous legislation I just discussed, a delay by 30 days, a requirement from the Families First package that a state maintain premiums to receive that 6.2% FMAP increase for funding. The bill also delayed scheduled reduction to disproportionate share hospital, also known as DISH payments, until December 1st, 2020. And this is a federal law that requires state Medicaid programs make DISH payments to qualifying hospitals that serve a large number of Medicaid and uninsured individuals. It's been an ongoing topic in Congress of reducing the payments down, but with everything that's going on, it was decided to delay this in the meantime. So a couple of, on the federal action piece, I'm going to speak to the federal agency level, primarily CMS, the Centers for Medicare and Medicaid Services. They come out with guidance on a daily basis. So I'm going to highlight just a few for this audience today. On mid-March, they released guidance for all-inclusive care for the elderly, also known as PACE organizations. And so the folks that are enrolled in these programs, Medicare and Medicaid beneficiaries that participate, they typically have chronic conditions and they're older, so they could be at a higher risk for COVID-19. So the guidance is offering actionable information for the PACE organizations that have these enrollees on accepted policies and procedures that they can use with regards to infection control. And a lot of it is giving flexibility, shifting from what had to be an in-person appointment or in-person follow-up to more telehealth, over the phone, things where people don't have to risk themselves for coming in for services that could be done in a different way. Another update that came out that has been covered pretty widely is 1135 waivers. The administration enabled CMS to waive certain requirements in Medicare, Medicaid, and CHIP under Section 1135 Emergency Authority. And since then, CMS has started accepting and improving state Section 1135 Medicaid waiver requests. Our speaker from NAMD is going to go into more detail, so I will leave it at that. CMS also came out with an announcement earlier this month giving states more information on ways to identify opportunities for telehealth services that can help increase access to Medicaid services, as well as federal reimbursement for substance use disorder services and treatment, also referred to as SUD. And this can include services and federal reimbursement for these services in school-based health centers. The information that was sent out can cover for rural health care and Medicaid telehealth flexibilities in these areas. providing Medicaid treatment for SUD via telehealth. And some of the methods outlined might be familiar to some, as it was in the Support Act that was passed several years ago, but can use the methods from that bill, that law, in other instances like the current COVID-19 public health emergency. And then my final slide, the last two announcements that I wanted to highlight for everyone. There was a checklist toolkit that came out from CMS for Medicaid and CHIP programs. And this is concerning federal waivers and flexibilities in their program. And so it's a 4-checklist that will permit states to do a few things: access emergency administrative relief, make temporary modifications to Medicaid eligibility and benefit requirements, relax rules to ensure that those with disabilities and the elderly can be effectively served in their homes, and will also modify payment rules to support healthcare providers impacted by the outbreak. And the last announcement that I wanted to talk about, as we get a lot of information and requests from the provider side during all of this, at the end of March, there was temporary regulatory waivers and new rules that came out for providers in the healthcare workforce. It includes a lot of different provisions, and everything I'm covering today has a lot of detail, and it's all included in the resources slides I have. But if you have questions, please feel free to ask or follow up. So some of these provisions for hospitals and healthcare systems, it's allowing communities to do things like use the local ambulatory surgery centers to contract with local healthcare systems to provide other hospital services, permitting non-hospital building and spaces to be used for patient care and quarantine sites, as long as that location is approved by the state and it will ensure the safety of patients and staff. It allows hospitals, labs, and other organizations to perform COVID-19 tests at the home or in other community-based settings when acceptable. And is also allowing, as many people might have seen being covered recently, emergency departments to test and screen patients for COVID-19 at drive-through or off-campus test sites. Has also expanded the ability for ambulances to transport to a much wider range of locations across services. On the different provider provisions, I wanted to highlight they're also issuing waivers so that hospitals can use different practitioners like physician's assistants and nurse practitioners to practice in accordance with the state's emergency preparedness or pandemic plan. And it's also allowing a waiver for hospitals that can provide benefits and supports to their medical staff, including things such as daily meals, laundry service, for personal clothing or childcare services for physicians and other staff. So this is just a few of the announcements. Like I said, here are some resources, and this will be shared with all of you as well. But if you have questions, NCSL is also doing a federal agency update page with CMS and across all federal agencies, across issues. So I recommend also, if you have some time, if you're looking for specific announcement, to go to that page. And I will turn it over back to you. Thank you, Emily.
Thank you, Haley. So with that, we can take a couple burning questions if anybody has questions for Haley at this time. We will also have time for questions at the end of the presentation, but I'll just pause for a beat here to see if there are any questions from our audience. All right, well, as I said, we'll have plenty of time at the end of the presentations as well, so please be sure to put your questions in that chat box. So with that, I will now turn it over to Jack Rollins to discuss national trends in state Medicaid responses.
Great, thank you very much. This is Jack Rollins, Senior Policy Analyst for the National Association of Medicaid Directors, or NAMD, and I really appreciate the opportunity today to join you and share a little bit about how states are leveraging the variety of Medicaid authorities that have been made available throughout the COVID-19 national public health emergency. So we will go ahead and start with just a little bit of background about NAMD and who we are. So we are relatively young in terms of DC associations. We were created in 2011 to support state and territorial Medicaid directors. Prior to that, the Medicaid directors were within a larger Health and Human Services umbrella agency, and prior to that, there was a separate dedicated association for the Medicaid directors. NAMD is bipartisan and nonprofit, so we We represent, of course, all 56 Medicaid directors across the states, the District of Columbia, and the territories. So there's a diverse set of viewpoints there. But our core functions are really around creating a network of learning and shared experience across the state Medicaid agencies. As we like to say, our members will often tell us, in fact, that you don't really know what it's like to be a Medicaid director until you sit in their shoes. So there really is kind of a fraternity of Medicaid directors there, and we like to provide them the ability to network with their peers, share the ideas, their struggles, and their successes, and to commiserate with each other. We also elevate directors' perspectives on federal policy areas. That is my primary responsibility at NAMD, is our federal policy portfolio. So that's communicating with both the administration and with Congress on issues that are impacting the Medicaid program. Well, we also do some leadership development work for Medicaid directors and their senior staff, and we also collect and share some data about Medicaid directors and their programs through annual operations surveys. We have a board of 14 Medicaid directors that lead us, as well as an executive team of 3 Medicaid directors. So I'd like to do a quick review of the types of emergency authorities that are available, and as I do this, I will be describing what these authorities are in normal circumstances, as well as how they have changed or what is new in the emergency declaration. So I'll be focusing on a number of the areas that were already mentioned in our framing remarks, including the 1135 waivers, which are specific waivers that are contingent on the National Emergency Declaration. They have blanket applicability in Medicare, but it's a little bit different in Medicaid. Each state has to actually apply for specific 1135 authorities. There's also what CMS is calling a disaster relief state plan amendment. Now, normally a state plan amendment is the mechanism that states use to modify their basic Medicaid program. The Medicaid program is and how it functions, who it covers, how it covers them, how services are paid for, would ordinarily be described in the state plan, and the state plan amendment is the mechanism that states use to modify the state plan. So the disaster relief state plan combines with the 1135 authority that CMS has and allows states to implement a wide variety of policy changes. I'll also be talking about home and community-based service waivers with the 1915C Appendix K. So the 1915C waiver allows states to waive what is the statutory and mandatory Medicaid benefit for nursing facility services and provide those services in the home or in the community. So the idea is to allow individuals to stay in a setting of their choice where they may be more comfortable and not necessarily have to receive institutional services, although they may meet institutional level of care needs. So that's, in brief, what a 1915C waiver does. The Appendix K is an emergency authority that modifies that overarching waiver and allows states to make specific changes. And then last, but certainly not least, is the 1115 demonstration waiver. So this is not a unique disaster waiver authority. It's in fact the most flexible authority available to CMS in the states, where the states are testing new coverage and design approaches in the Medicaid program. CMS has developed a specific 1115 waiver for COVID-19, which I'll be talking about a little bit later. And before I really dive into the content, I do want to just spend one quick moment to acknowledge that from our perspective here at NAMD, CMS has been a tremendous partner throughout the pandemic. Really since the beginning, CMS has dramatically accelerated their approval processes and their overall support for states. They've been incredibly responsive both to us and to our members, which we really appreciate. We're seeing some serious investment in the state and federal partnership to support some of the rapid changes that states are making on the ground. And CMS has taken the overall attitude that states need to just do what they need to do operationally, make the decisions that need to be made, move quickly, and that CMS will work with the states to sort out the authorities, which bucket of authorities apply to sort of allow the state to do what they have already started to do, and to sort out the paperwork on the back end. That's a big change from business as usual for CMS. We really appreciate that stance. Not everything is perfect. There's always more work to be done and more issues to sort through, but this is a sea change in our view, and we really applaud the efforts that CMS and their staff are making during this difficult time to support states. It's our hope that there will be some durable changes to CMS's partnership and operations with state Medicaid agencies as we enter a post-COVID world, but we recognize that that's a ways away, and everybody is really still quite focused on managing the immediate needs of the day. So, starting with 1135 waivers. So as noted before, 1135 waivers give CMS some pretty broad authority to waive provider requirements, but the 1135 waiver does not allow changes to payment requirements. So there's an important distinction here. Essentially, the 1135 allows states to make a lot of modifications to provider conditions of participation in the Medicaid program, but if states want to pay providers differently, they need to use a different authority. CMS developed a Medicaid 1135 checklist to streamline the specific flexibilities. That checklist is populated with flexibilities that CMS understands it has a clear authority to waive. And so again, this is really focused on specific provider pieces. So things like waiving prior authorization requirements or extending current prior authorization periods, waiving certain provider enrollment requirements to allow states to just quickly ramp up their provider networks, including across state lines. The ability to waive ordinary public notice and comment requirements that would attach to other waivers. So for example, a state plan amendment that would make a payment change would ordinarily need to go through 30 days of public notice and comment. And an 1115 waiver would also need to go through a public notice and comment period. CMS is currently waiving those requirements. There's also abilities to waive certain fair hearing timelines. So if a Medicaid beneficiary wants to appeal a sort of a negative coverage determination, the states would have certain timelines, either the states or their managed care plans would have certain timelines to resolve that and transition to a state fair hearing process. CMS is allowing those timelines to be modified. There's also ability for states to request modification of supervision and oversight requirements for certain practitioners. So that would allow, for example, a physician assistant or a nursing or a practicing nurse to be able to provide certain services without having a physician directly overseeing that provision. An important thing to note, though, is that states have requested a lot more than what's in that checklist, and CMS has acknowledged that some states may be interested in moving beyond, whether doing payment changes or other changes on the provider side that aren't captured in the checklist. And that requires generally some further consideration, either internally at CMS or further negotiation with the state. And it may produce an outcome where the state is actually going to get what they're asking for, just not under an 1135 waiver, but through some different authority. So that transitions us into this disaster state plan amendment. Because this is one of the main authorities that states can actually get some of the things they may have asked for in an 1135 waiver submission. So the state plan authority, the template that CMS has put together, is really quite comprehensive. It gives states a wide array of flexibilities for implementing various changes in their programs. Just a flavor of what that includes are things like expanding optional coverage populations, including adopting the Families First Coronavirus Response Act's uninsured testing option that was mentioned earlier. We're seeing a lot of modification of telehealth policies and payment structures to support telehealth, expansion of presumptive eligibility, such that a hospital may be able to determine an individual in their hospital presumptively eligible for Medicaid on the basis of being aged, blind, or disabled, which is a change from current rules, or the state is able to expand what types of settings or providers can conduct the presumptive eligibility process. Normally, it would only be something that hospitals can do. States are also able to modify their enrollment policies and redetermination periods, and we're seeing a lot of states do that to comply with the conditions of the enhanced FMAP that's available under FFCRA. So the 6.2% increase has various parameters for continuous enrollment, as well as making sure that state eligibility processes are no more restricted than they were on January 1st. So this disaster SPA template is one of the primary mechanisms that states are using to implement those changes if such changes are necessary in the state. We're also seeing a lot of modification around pharmacy prior authorization rules, as well as length of prescription fills. So to minimize Medicaid beneficiaries having to go to a pharmacist to refill their meds on a frequent basis, states are extending those lengths of fills to 30 or even 90 days, as well as creating flexibilities for mail delivery and electronic signatures just to minimize the need for face-to-face contact. So while we're seeing a lot of activity under this authority, I'd say that probably the most common one that we're seeing across the states is the rapid expansion of telehealth and telehealth-related changes, as well as I mentioned, the changes to meet the conditions of the FFCRA's enhanced FMAP. I think that the telehealth expansion is something that just about every state is implementing. We're seeing really a dramatic increase, and there are some states where as recently as perhaps a month to a month and a half ago, had barely any telehealth policies, are now all in on telehealth. It's really quite dramatic, the rapid expansion of telehealth, and I think it's one of the things that we're all hoping will endure and persist after we get through the immediate needs of the COVID-19 emergency. So I'll be happy to talk more about that if there are questions. Moving on then to the Appendix K waiver and 1915C waiver. Appendix K in 1915C waivers. This is really about maintaining Medicaid's home and community-based services provider infrastructure. So the Appendix K is unique specifically to 1915C waivers. So it's a pre-existing authority, which is to say that states could have had an Appendix K in place prior to COVID-19, but not necessarily every state did. And certainly no state had one that was tailored to COVID-19 until the pandemic was upon us. So I think it's fair to say that most states are filing Appendix Ks now to respond to COVID-19. So the Appendix K allows a number of modifications to waiver programs, and they can persist for up to 1 year, so it's a relatively long-lasting authority. States can modify the income and targeting criteria for eligibility in a waiver, so they can increase the amount of assets, for example, that an individual living in the community can have and still be considered eligible for their services, or they can expand the types of individuals and the types of service needs that have to be present for eligibility purposes. States can also add new services to be covered within the waiver or increase the limits on existing services within the waiver. They can expand the eligible sites for services to have more types of providers able to provide them. Expand who can be a paid caregiver under a waiver, including family members, as well as relaxing caregiver licensure requirements, again, with the aim of maximizing the availability of providers in the community. They can increase provider payments to account for COVID-19. And the most interesting authority from our perspective here at NAMD is what is called a retainer payment. And what this means is that the state can pay a specific set of HCBS providers. They are providers who provide what's called habilitative services. They can pay those providers for services that would have been rendered, but they can currently not provide those services to specific individuals because that individual is either not able to go to the provider or is otherwise in the hospital for COVID-19 reasons. So the individual may be in quarantine or may be hospitalized. So this allows the state to essentially pay as though the services were still being provided and keep that provider in business and able to render services. I will talk a little more about that because this is a construct that we would like to see expanded to a number of other provider types. So focusing a little more on the retainer payment issue, a key priority that our members are seeing is that Medicaid providers are having real challenges staying solvent in the COVID-19 pandemic. There are a number of Medicaid providers that are not hospital-based, are not institutional, are relatively small, financially fragile, really kind of mom and pop operations that the federal government may not have the best line of sight into to direct resources to assist. So the Appendix K retainer payment structure is a helpful option, but it doesn't reach all the providers that we're thinking about, because we're thinking about federally qualified health centers, we're thinking about behavioral health providers, substance use disorder providers, opioid treatment providers, non-emergency medical transportation providers, school-based health service providers who can't provide services because schools are closed, as a non-exhaustive list. There are a number of others. We're hearing concerns from pediatricians and children's hospitals. The need is quite acute and across a number of sectors. The challenge that we are seeing is that CMS has some reservations about duplicating the existing federal dollars that have been allocated in the CARES Act. So folks are hopefully aware that the CARES Act has a $100 billion fund for providers to address provider solvency needs and make up for revenues that are lost due to COVID-19. We have some concerns that those funds aren't getting to the providers that I'm talking about right now. $30 billion of those funds have already gone out, that they were allocated on the line of Medicare fee-for-service utilization. So that means it primarily went to Medicare hospitals, Medicare Part B physicians, and some nursing facilities, but left out a wide swath of providers that are still in need. So NAMD has asked Congress for the statutory authority to expand the retainer payments to any provider, and we're continuing to work with CMS to try and put some guardrails around how these payments could work outside of the Appendix K context. I'm happy to talk more about that because that remains one of our #1 issues. Then finally, moving on to 1115 waivers. So the 1115 template that CMS has put out is really narrowly focused on allowing states to replicate that Appendix K waiver outside of a 1915C. And the reason for that is that states may use a non-1915C authority to deliver HCBS. So they may be using their own current existing 1115 waiver. They may be using a state plan authority, such as Community First Choice, to deliver HCBS. So CMS is essentially saying that no matter how you deliver your HCBS in Medicaid, you will have the ability to do what an Appendix K would let you do. The 1115 template also allows states to accept individual self-attestation of income with the intent of speeding eligibility determinations for Medicaid. To date, none of these 1115s have been approved, but we do know that a number of states have them pending with CMS, and we do anticipate that there will be approvals very soon. However, state interest in 1115 waivers for COVID goes well beyond what CMS has outlined in the template. We know that there are a number of states that have asked for retainer payment authority for a wide variety of providers through an 1115, and those negotiations are ongoing. So just to wrap up my remarks, I hope that this provided a very quick overview of the wide array of authorities and flexibilities that are available to states, as well as the templates that CMS has provided to the states to support some quick processing for the things that CMS knows that it can say yes to. There is continued need to explore the authority pathways for state strategies that don't fall neatly within those templates and those parameters. CMS has really not said no to many of these things, but they haven't said yes yet. They're navigating some of the legal authorities and budgetary questions does require a bit of time. We understand that, but we do hope to see some resolution soon. So there also is some work that remains on how states can replicate some of those blanket Medicare flexibilities and how those Medicare blanket waivers intersect with Medicaid policies at the provider level, and a better understanding of what states need to do and what authorities they need to use if the states want to implement the same things that Medicare is doing. So that's another outstanding issue. But with that, I will go ahead and wrap up and maybe hand things back.
Thanks so much, Jack. So again, we can take 1 to 2 burning questions for Jack at this time. Again, we have time at the end of presentations as well, but I'm just going to pause a beat to see if there are any questions. Reminder, the audience chat box on your left, you can put questions in there. All right, again, we can take questions at the end. So for now, I'm going to turn it over to Josh Bloch to share Colorado Medicaid's response to COVID-19.
Hi, everybody. My name is Josh Bloch. I am the Budget Director for the Colorado Department of Healthcare Policy and Financing. We are the state agency in Colorado that administers the Medicaid program, also our children's health insurance program, along with a number of other state-only healthcare programs that occur in Colorado. Today, I'm going to talk a little bit on 3 different topics. I'm going to talk a little bit about what Colorado's Medicaid program has done specifically related to emergency actions associated with the pandemic. I'm going to talk about what we're seeing in terms of short-term effects on Medicaid spending and how we think that things are going to shape up, at least in the near-term future. And then I'm going to switch gears a little bit and talk a little bit about strategies on how to reduce Medicaid expenditure during economic downturns. That's on all of our minds, I suspect, lately, as we're all faced with a lot of budget shortfalls here. So I'll start off with just discussing our emergency actions. And for us, it starts from the place that our legislature is out of session. They are taking a little bit of a hiatus while the pandemic runs through Colorado here. In the meantime, what we're trying to do is we're trying to leverage our federal flexibilities, and we're trying to work within our existing budgeting and legal authority that already exists, because we can't go to the legislature and ask for a change of law right now. Interestingly, we're taking advantage of a lot of the things that Haley and Jack both talked about during their versions of their parts of the presentation here, and you can see that we're starting here in terms of program flexibilities, in particular the expanded use of telemedicine. Jack talked about that a whole bunch, and it is absolutely one of Colorado's core strategies in terms of trying to maintain healthcare services and make sure that people can get services. We're seeing telemedicine being provided in places that we never thought possible before, things like speech therapy or physical therapy. There's actually a component of stuff that can be done virtually, which I found really interesting. So we've tried to allow for flexibilities related to that. We're expanding the settings where services can be provided, a couple core examples there. We're certainly looking for inpatient hospital capacity, as we're trying to make sure that people that don't need to be in a hospital proper aren't there. I'm sure everybody has heard stories of field hospitals being built, and trying to find ways to allow our hospitals to get paid for the services they provide in those type of locations, a really important one to us. We're also seeing stuff being performed in alternative locations under the home and community-based services umbrella. So, for example, if somebody has a deficiency in activities of daily living, they need help getting dressed or moving around, we are able to provide those settings, or we're authorizing those services to be provided outside of the home. For example, if somebody is in a hospital, we can have them bring a personal care attendant along so that they have help in a situation where they might not otherwise. We continue to work on prior authorization requirements and extending pre-existing prior authorizations. So another thing that both, I think, Haley and Jack talked about, things like pharmacy refills were a really good example of that. Home health prior authorizations, if somebody hasn't had a change in circumstance and they're in the situation where they need just an update to their service plan, we are giving people extensions on some of those requirements, just so that people don't have to have these in-person visits, or when our case management agencies are not fully staffed and they're working from home, that there are ways to ensure that people don't lose coverage. And then we're also doing things related to providing payment for services provided by family caregivers, something that happens in the home and community-based services world. This is an interesting little nuance inside of home community-based services, where there are certain options where personal care and homemaker services can be provided by people without medical degrees. However, there tend to be prohibitions about when your legal guardian or other family caregivers provide it, because there's a shortage of providers and people are worried about going into people's homes. We're trying to expand the number of providers that are available to provide some of these services, so we really kind of leaned in hard there. I skipped over the bullet about rate increases and retainer payments. Jack mentioned that a lot. We've definitely authorized retainer payments, particularly in the home and community-based services world, where we know that those providers are struggling and sometimes live on the edge of financial stability. We're exploring rate increases for other providers as well, particularly nursing facilities, where we know that they're going through a tough time and having difficulty retaining staff. So we're working a lot on the program side. On the other, at the same time, we're also working through a lot of administrative flexibilities as well. So again, a bit of a duplication of what both Haley and Jack said. However, we're doing things like extending the time to act on changes in circumstances that affect eligibility. So if you have had a change in income, or you need to submit some type of paperwork or documentation in order to maintain eligibility, we're extending some of the time frames around that, allowing for self-attestation of certain eligibility requirements such as income, waiving timelines for functional assessments. Again, that applies primarily to home and community-based services or home health worlds. Modifying licensure or other requirements. So again, this goes back to the idea of field hospitals, or allowing services to be delivered in an alternative location, trying to make it easier for providers to enroll. If folks need to join Medicaid because now suddenly they are being tapped in to help provide care, we want to make it as easy as possible for them to join our program. And then suspending some supervision requirements and then some administrative requirements on site visits and audits. It's worth knowing that these flexibilities are temporary, both on the program side and administrative side. These are the type of things that under normal circumstances we might say have a budget impact. However, in a pandemic and in a crisis, they are the flexibilities that we're allowing to make sure that care can continue to be delivered. So we're trying to take advantage of as many flexibilities as we can from the federal level within the bounds of our state statutory and legal framework. So I'm going to switch gears a little bit here for the first time. And the first thing I'm going to talk about here are the sort of short-term effects on Medicaid spending, which I know are on a lot of people's minds. You know, as states are seeing their revenues decline, we're starting to wonder about, you know, what our programs are going to look like going into the future. So the interesting thing is that the caseload effects from this are actually very uncertain. We have seen this surge in terms of unemployment applications, which is going on all across, and the numbers are downright astounding if you're following the weekly information from the Federal Department of Labor. However, we have not yet seen those unemployment applications translate into Medicaid applications. There are a lot of reasons for that to potentially happen. For example, if you lose your job, you might still be in a household where somebody is working and therefore you don't qualify. You could be using a program such as COBRA, which would allow you to maintain your health insurance after you lose your job. It might also be that, you know, you don't need health insurance right now. You could be looking at it like, all right, well, I am generally healthy, so I don't necessarily need to apply for another healthcare program right now. You know, and things of that sort. So far, we haven't actually seen much of a surge in terms of new Medicaid applications. Now, what we are seeing is that our caseload is rising because the federal law related to the additional federal funds prohibits us from disenrolling anyone from Medicaid for the duration of the emergency. So in the short term, we're absolutely going to see our caseload swell. It's a question of how much it's going to grow from just people who would have dropped off the program that aren't, and how many new people that we're going to see. Again, it's interesting to note that our counties and many of their offices who in Colorado process applications for us, that they have not, many of their offices have been closed, and so they're not processing all the applications. We're trying to divert folks to online applications. However, that's, and those efforts are ongoing, but we're still not seeing it translate. What's really interesting, and something that I think is really counterintuitive to where we are and how it turns into, you know, the changes in our revenue and, you know, what states are going to have to do, is that in the current fiscal year, we actually expect our Medicaid spending to go down. And that is almost unfathomable to those of us who work in the industry and have been doing this for a while. But the reasons are fairly straightforward. And the idea is that we are seeing that for most providers, utilization has just absolutely dropped off a cliff, that people are foregoing most routine and non-emergent services, things like elective surgeries or surgeries that they can put off. People aren't showing up for wellness checks, which means that there are declines in physician visits. There are also declines in laboratory and x-ray type of services. Home health is dropping a lot as people are afraid to go into other people's homes or afraid to let people into their homes. Transportation is dropping for similar reasons. Home and community-based services are other examples where, you know, somebody might go to an adult day program, or somebody might have a particular behavioral health specialist show up. Again, those services simply are not being rendered. And we talked earlier about retainer payments and rate increases. That's one of the things that we are most afraid of, is that when people can't bill us from services and they don't have revenue coming in, they can't pay their staff. And so when we need them as the pandemic ends and we move into the next phase of this, we have to make sure that those providers are still afloat and they're still able to provide services to Medicaid clients. What's interesting is that you know, there has been some level of help from the federal government in terms of Medicaid, and the big way that they've done that is by changing our federal matching rate. So that's a blanket 6.2 percentage point bump in the federal matching rate across the board for all states. For Colorado, just to try to make the math real for folks, that brought us from 50% federal funds to 56.2% federal funds. That is actually for some populations, but not all. Any population that gets the enhanced federal match at 90% under the Affordable Care Act, those populations do not receive any additional federal funding. Again, as Jack and Haley mentioned, terms and conditions apply. So we can't disenroll people from Medicaid, we can't reduce the benefits, we can't increase premiums. There are a number of things that we are prohibited from doing while we are retaining, or while we are getting this enhanced, these extra federal funds. The enhanced FMAP is the term. I'm trying to stay away from acronyms here. What's interesting is how that money helps us and how it doesn't. So this is a very Medicaid-centric call, and what's interesting is that this increase in federal funding for Medicaid, at least in Colorado, does not go to help. It does not go directly to help the Medicaid program. In Colorado, there are actually limitations on our appropriations related to if we get higher levels of federal funding, it means that we cannot spend the same amount of Colorado General Fund. And so even though a lot of people are out there believing that Medicaid is sitting on a giant pool of additional federal funding, in Colorado it doesn't actually work that way. For us, it's actually that that funding goes directly to our general fund, and it helps the state out with other various revenue shortfalls and other programs. Obviously, we need our share of that as caseload potentially increases, and it serves to it serves as an offset to other state needs, but still the need is widespread. The thing going forward for us is that there are considerable data challenges related to what is actually happening. From our standpoint, there's this huge lag between the time that services are provided, the time that services are billed, and then the time that the services are paid. And from our standpoint, we don't see the data until after claims are paid. For some providers, that actually happens really quick. So pharmacy, for us, pays really fast. We see that data in a week or two. For hospitals, we don't always see complete data for 2 or 3 months. So we don't actually know what's happening until after it's happened. So what we're trying to do is gather a whole bunch of anecdotal information coming from our providers, from our members, and from everybody else to tell us what they're seeing, because the big question for us in terms of the state budget is how is our fiscal year 19-20 going to end up? Will Medicaid expenditure spike in 19-20? Will it spike in 2021? We're trying to figure those questions out now, and they're pretty difficult to solve. There is one question in the chat about our pharmacy prices still going up this year compared to previous years or at the same rate. We are actually seeing that. It has been a big ongoing concern for us, particularly related to specialty drugs. Generics are plus or minus, and it depends on it depends on the individual drugs. But yeah, we are absolutely seeing pharmacy prices continue to rise. Our last little segment here is about how we reduce Medicaid spending. I know that's on a lot of people's minds, whether we want to deal with this topic or not, just because of our revenue shortfalls. And what I'd like to just kind of run through here is that there are really 6 ways. When you think about this broadly, there are 6 ways that you can reduce Medicaid spending. The first lever that you can pull here is that you can reduce eligibility. Certainly can't do that while the emergency FMAP or the emergency period is in effect, but it might be an opportunity for the future. The second thing is that we can reduce benefits, right? Reducing benefits, again, enjoined by the federal law at the moment, but something that may need to be considered going forward. Just trying to reduce the Medicaid, the overall benefit package related to that. I'll get back to that here in a second. We can always reduce provider payments. That's just a provider rate cut. That one's always tough because our providers are having difficulty staying afloat now. Provider rate cuts don't help that type of situation, but sometimes tough choices need to be made. Beneficiary responsibilities related to, could you increase copays or payments? You have to be careful with those. Again, some technical changes or some technical difficulties there related to the FMAP provisions, but also copays are related to provider cuts. So you have to be careful about that. You could also do some other things like change your delivery system, switch from fee-for-service to managed care, or change to, making changes to your program integrity, such as, doing a better job of policing fraud, waste, and abuse and things like that. So again, these things really do turn into difficult choices. Just a couple of anecdotes here. The first thing to know is that you have to cut higher income populations before you cut lower income populations. That's difficult for us in Colorado because higher income populations, not only are they children and parents, but also they're funded with cash funds. So if you remove potentially hundreds of thousands of people from the rolls, you still might not get any general fund relief. Your mileage might vary on that, so you need to check with Medicaid agencies, but be careful about how your higher income populations are funded. Same thing with benefits, right, is that you could potentially reduce benefits, but optional benefits are, in Medicaid, don't quite mean what everybody thinks they mean. It's a weird distinction in the Social Security Act, and optional benefits in Medicaid actually mean prescription drugs, home and community-based services, dental services, and things like that. So you have to be very careful when you talk about, what optional things in Medicaid exist to cut. Because they don't always mean what they think people mean. Provider payments are probably the easiest way to get savings. Again, it just comes right out of our providers' reimbursements at a very difficult time. So those are some tough choices there. And then beneficiary responsibilities. Things to keep in mind there that there are federal maximums related to co-payments, and those federal maximums are pretty small. It's worth knowing that most people in Medicaid can still receive services even if they refuse to pay a copay. So sometimes copays are just another way to reduce provider reimbursements. And then finally on premiums, standard federal authorities prohibit premiums for people underneath 150% federal poverty level. Alternative authorities to potentially charge premiums to more people could come with difficult choices, maybe terms and conditions such as spending caps. That is the high level on where we might be in terms of reducing Medicaid benefits. I'll turn it back over to Emily and the NCSL team for questions. I appreciate that you all let an executive branch guy talk to a bunch of legislators. It's always a pleasure to be able to have a little bit of cross-government talking here. So thank you very much for the opportunity.
Well, thank you so much, Josh. So now we do have time for questions for Josh, but also for our other presenters. So while we wait for questions to come in, we do have a question in the box. And I'm going to direct this question to you, Jack. The question is, could 1115 waivers address provider reimbursements for out-of-network services?
Hey, great question. So I think in the context of this question, we're obviously talking about kind of managed care provider networks. And what we're seeing with the COVID-19 response is that a lot of states directing managed care plans to provide coverage for testing and treatment regardless of where that occurs. And so there are some options either through an 1115 or through existing regulatory authority and managed care contracts for states to accommodate that. And there's actually a bunch of different ways that you can do it. The state could actually just create a general sort of what's called a kick payment to a managed care plan. So a payment that's not necessarily risk-based, but is layered on top of the existing negotiated rates to account specifically for COVID-19. The states could create a risk corridor so that the managed care plan won't be left too much on the hook financially for providing the services out of network. The state could also make some either retroactive rate amendments or amend rates going forward. So there's a couple of different options, and all the ones I just described don't necessarily require 1115 waiver authority. Those are all things that states could negotiate with their plans and with CMS under the current managed care regulatory structures, which primarily happens through the managed care contract itself and the rate certification process with CMS.
Nice, thank you. So we will probably be wrapping up right at 2 o'clock here, but if we don't get to your questions, we will respond offline. So please enter those questions in the question box if you've got them. But at this point, I do have another question for you, Jack, and Josh, you can chime in if you have anything to add as well. But wanted to ask you, you mentioned all the support you were receiving from CMS and how responsive that they've been. And I'm wondering if you could speak to, what additional flexibilities could states see at this point? What would they be looking for, whether it's something NAMD specifically asked for, just discussions you're hearing at the state level, just some additional supports that might be needed at this time?
Sure. So I'd say that the number one issue is definitely the retainer payments, as I described in my remarks. So the need for states to have the clear authority to make payments to Medicaid providers that are either already closed or at imminent risk of closure due to significantly decreased service utilization. Our concern here is that we need to be on a strong footing in terms of the Medicaid provider infrastructure to respond to increased enrollment that we're all anticipating is going to happen as we enter into an economic downturn post-COVID. Other issues that we're definitely seeing some interest in beyond that one, which again I think is far and away the most critical issue, is mostly around some of the operationalization of the maintenance of effort for the enhanced FMAP and how it intersects with specific populations. We're seeing a lot of questions around those requirements and individuals who may age out of a CHIP program, for example, or folks that age into Medicare but were previously on Medicaid, and just how exactly that functions. So clarity there would also be helpful. I think those are a couple of the major issues, and there's many smaller ones, but I think those are the outstanding things. But I'd be happy to hear some of Josh's thoughts from the Colorado perspective as well on things that you're looking for but quite haven't gotten to yes with CMS on.
Yeah, thanks, Jack. From my standpoint, it's a lot of the operational stuff that we're worried about with CMS. One of the things that is always a concern for us is when our state agency does something wrong and the Department of Health and Human Services sends the Office of the Inspector General after us, and they request, they want us to put money back. We're working as fast as we can, and I can certainly tell you that this last month has been an absolute whirlwind. So some of the things that I'm hoping to see from CMS is maybe some flexibility about, what happens when we do stuff wrong and how we get it back to right. One of the things that was a real challenge for us was trying to change our eligibility system on the fly. When Congress passed the Families First Act and all of a sudden nobody was allowed to be disenrolled from Medicaid, we had to go back and retroactively make sure that people weren't disenrolled from our program and then send out notices and all those type of things. And we're trying to make sure that at the end of this, there isn't a giant bill that we're going to have to pay back to the federal government because we didn't do the paperwork right, or somebody filled out a form wrong. So we keep pushing on CMS for that angle. But I think, Jack, that you kind of nailed it, right? The retainer payments is a huge one. Trying to make sure that our providers can be viable is another one. I think that we're in a very interesting circumstance where most of the federal money that is coming out does not come through Medicaid, only the FMAP does. Most of it goes directly to our providers, and so it's interesting in that it's so much out of the hands of the Medicaid agency going forward. So we're working through some of those things.
All right, well, thank you both for that response. And at this point, we are at time. Matthew Holmes, I see your question about particular Medicaid providers that are generally less solvent, and we will get back to you outside of this webinar, but should have information to provide for you there. But I just want to thank everyone for their participation in today's webinar. I want to thank our speakers for sharing their expertise and insights. I would also like again to thank the Commonwealth Fund for their support. At the end of this webinar, there will be a very short survey that will pop up on your screen. We'd really appreciate you taking the time to provide your feedback. We always find that very valuable. And again, this webinar and other COVID-19 resources for states can be found on our website at ncsl.org. Thank you all so much.